Hey all, welcome back to the Real Life Pharmacology podcast. I hope you're enjoying it so far. If it's your first episode you're listening, thank you so much, and hopefully you can find some clinical practice pearls that are relevant to your practice or maybe help you in your board exam or pharmacology exam if you're still in school. So today the drug of the day is codeine, and with this medication, I will say that I've practiced pharmacy for over 10 years now, been in various settings, long-term care consulting, ambulatory care right in a clinic, in a retail community pharmacy, and the use of this drug has definitely declined over time. And I'm going to give you some examples as to what makes codeine so special and so unique as we go through the podcast here. So mechanistically, I think the important thing to remember, codeine is an opioid. So like many of the other opioids, like hydrocodone, for example, that I've covered, it binds the CNS opioid receptors and ultimately stimulates them. This reduces that perception of pain. That's ultimately what opioids do in the central nervous system. They don't act at the site of action. So if you've got pain in your finger, it doesn't help with inflammation or anything like that. It basically blunts these signals that are being sent to the brain. And that perception of those signals is essentially how opioids work. Brand names, Tylenol number 3 is the one that I recall most vividly from my memory. And I would say I don't see it very often anymore. And again, like I said, it's just some of the complicated things. But when I first graduated and was going through internships, things of that nature, in the 2000s, late 2000s, I definitely saw a fair amount of Tylenol number 3. So with that said, adverse effect profile is going to align with opioids, of course, sedation, respiratory depression, more so in higher dose overdose situations or in combination with other drugs that can complicate that. Constipation is obviously prevalent and occurs at a significantly high rate with opioid use. GI upset, allergic reaction, all things that can potentially happen with the use of codeine and opioids in general. Of course, we've got to remember the more you use opioids, the more likely we're going to run into physical dependence. Opioid addiction can certainly happen on account of codeine as well as any other opioid. So really important things to educate our patients on, and also to monitor that use and ensure that we're not escalating doses. Because remember, with opioids, that tolerance tends to develop, and that can be one of the factors as to why patients try to continually escalate their dose. So very important to watch out for those things for sure. So other things to think about if it is Tylenol number 3 that's being prescribed. So that's going to have acetaminophen in it, obviously. And if patients are escalating doses to get the opioid effects or to get more opioid effects, they are also increasing their Tylenol dose or their acetaminophen dose. And as we know, when you get to above 3,000, probably more likely 4,000 milligrams and higher, we're going to increase the risk for liver toxicity. So paying attention to that use is super important, and also the education point of saying, hey, you can't, or depending upon how much Tylenol number 3 they would be taking, you shouldn't take much more Tylenol over the counter in combination with this, because we've got that potential of getting excessive doses and increasing liver toxicity. So definitely a lot of patient education that may need to be done there to ensure our patients are using it as safe as we possibly can there. All right, so I'm going to spend the bulk of time. If you want to listen to some of the other opioids I've gone through, I think I've done hydrocodone, I think I've done fentanyl, but I really wanted to spend a good chunk of time on pharmacokinetics and pharmacogenetics or pharmacogenomics, and specifically CYP2D6. So codeine is a really unique medication, and I've seen this numerous times on numerous different exams throughout my career. CYP2D6 is the enzyme that actually converts codeine into morphine. Now, morphine is a much more physiologically active compound than codeine, which is generally considered inactive. So what this means is to have pain-relieving analgesic effects, you need this enzyme, CYP2D6. Otherwise, if it's blocked, if it's not active, you're not going to get or going to have less opioid-type effects. Now, in the case of pharmacogenomics, if you've got a very active, sometimes we'll call this a rapid metabolizer, at the enzyme CYP2D6, you can escalate the conversion of codeine to morphine, leading to greater concentrations of morphine in a shorter amount of time. So this can increase the likelihood that we have excessive opioid actions, potentially leading to overdose, respiratory depression, and all the bad things associated with opioid overdose. So a patient's genetics can alter the way that a patient is going to respond. So if we don't have testing, which we generally don't for a lot of patients, that really complicates the use of codeine. Because in one patient that's not a rapid metabolizer, we may have minimal effects or maybe a modest analgesic effects. And in a patient that is a rapid metabolizer, we may get excessive adverse reactions and the risk for overdose. So it's very important to recognize this, and this is one of the downsides of using codeine, is that it's not an active drug and requires enzymatic activation. Okay, so I just wanted to go through that, and that's one of the principal education points in pharmacogenomics is patients can break down, or in this case activate, drugs at different rates. And because of that, we can get different responses. So anyway, it's a very hot topic area in the last 5-10 years, huge area of growth and learning and that type of thing, and we're learning more and more about individual drugs. And if you've got questions on that, I would definitely encourage you to reach out to a fellow pharmacist, because we've definitely had some training in it, and I would say, being in the medication space, we're definitely on the cutting edge of a lot of the information that comes out. And there's definitely some drugs where we don't, particularly maybe older drugs, where things aren't being studied as much because we're not having that funding necessarily. But it's a really important thing, and we do know for some drugs what enzymes or what primary enzymes are the pathways. And we can, alter dosages, be more conservative, be more aggressive, depending upon the pharmacogenomics of the patient. So, very important concept to recognize, and it may explain why some patients have adverse effects and other patients don't seem to respond to the drug at all there. Now, I will also say, and I'm going to do this after the break, but I'm going to talk about drug interactions and how obviously that enzyme plays a role there. So let's take a quick break from our sponsor, MedEd101.com, and we'll finish up with drug interactions. If you're a pharmacist or pharmacy student in the market for board certification study materials like NAPLEX or the geriatric exam, pharmacotherapy, ambulatory care, or the new medication therapy management exam, definitely go check out meded101.com/store. I've got a growing list of resources there. If you're a clinician, maybe a physician, med student, NP, PA, and you're prescribing medications, definitely go check out meded101.com/store. Got a lot of clinical practice pearls, case studies, case scenarios, and a lot of clinical reasoning that I've learned from my experience in working with patients, working with other physicians, whole host of different healthcare professionals. So definitely go check out those resources, support the sponsor, meded101.com/store, and help keep this podcast free and educational for all to enjoy. All right, so let's finish up on drug interactions. The first thing I wanted to kind of get out of the way, mention, we need to think about overdose situations with any opioid. Benzodiazepines increase that risk for respiratory depression and the likelihood of a severe outcome, bad outcome, in patients who are taking opioids. So definitely important to remember that. I've talked about that on previous opioid podcasts as well. 2D6. So CYP2D6 plays a big role. And like I said, it converts codeine into the more active morphine, which is then further converted, but I'm not going to get into too much detail there. But CYP2D6 inhibitors, so blocking that enzyme, could potentially reduce the opioid activity. So a patient might not respond to codeine as well if they're taking a drug like paroxetine, fluoxetine, amitriptyline. All these drugs may have some CYP2D6 inhibitory action, thus reducing the effectiveness of codeine as far as its analgesic properties. CNS depressants, I definitely want to mention them as well. So codeine, like any opioid, is sedating. And any type of medication used for sleep, any anticholinergic medication, seizure medications, alcohol, anything that has CNS depressant activity could potentially have additive effects onto codeine and opioids in general. And then, of course, constipation I wanted to mention as well. So if you've got a patient on, let's say, highly anticholinergic medication and codeine, it could really ramp up that effect of constipation. And then lastly, I will mention CYP3A4. So CYP3A4 inhibitors can actually increase the active metabolites of codeine further down the pathway of that conversion from codeine to morphine. Well, then we get the breakdown of morphine and other metabolites by CYP3A4. So if you've got a CYP3A4 inhibitor, that could prolong the action of those active metabolites, causing an increase in essentially codeine's effects or morphine's effects if we're talking about the actual compound that it's broken down into. Inducers of CYP3A4 would potentially have the opposite effects, where it would reduce those concentrations of the active drug more quickly and ultimately lead to a reduced opioid response. All right, so I think that's going to sum it up for today. Thank you so much for listening. If you enjoyed the podcast, leave us a rating, review on iTunes. That's greatly appreciated. Share us with a colleague, a friend, a classmate, a student that's maybe working with you. Definitely help spread the education. We greatly appreciate that. And support our sponsor, meded101.com/store as well. If you'd like to track me down for consultations, special questions, probably the best way to do that is on LinkedIn, Eric Christensen, PharmD, BCGP, BCPS. Also, you can send an email through meded101.com and reallifepharmacology.com as well. Either spot there, and that comes directly to me. So I'm going to sign off for today. Hope you picked up a few practice pearls, and have a great rest of your day.
Okay, round 2. Name something that's not boring.
A laundry? Ooh, a book club. Computer solitaire, huh?
Sorry, we were looking for Chumba Casino. That's right. ChumbaCasino.com has over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.